This panel will be moderated by Dr. Alex Howard, the Vice President of Health and Wellness for Dogwood Health Trust. Our panelists include Rachel Bernis, Administrative Director, Department of Community and Public Health at MAHEC, Dr. Richard Hudspeth, CEO, Blue Ridge Health, Dr. Brianna Lombardi, Deputy Director, Carolina Health Workforce Research Center for the Sheps Center of Health Sciences Research, Dr. Lori Anderson, Dean of College of Health and Human Sciences, Western Carolina University, and Melissa Hyatt, Dean of Health Sciences, Southwestern Community College. I'd like the panelists and moderator to come forward, please.
Good morning, everyone. Well, thank you. Certainly appreciate that. So my grandmother would always tell me, whenever you walk into a space, you enter into that space with gratitude and joy. So from the framework of gratitude, I want to say thank you. Thank you to the team at UNC Asheville, the chancellor, staff and team. I also want to call attention to, there was an apology made for the weather. I would like to ask that apology is redacted or removed. And I say that from the perspective of, as a first generation college student, universities represent opportunity. And it's never a bad day to be on a university campus. No matter the rain, sleet, or snow, it's a place of opportunity. And this morning we opened with a beautiful conversation regarding Medicaid and its impact, and there were a number of people who referenced opportunity. This panel that is assembled before you will talk about workforce, needs, and opportunities, emphasis on opportunities. I also want to slightly deviate from what I probably should be talking about and call out Casey Cooper for, yes, Casey, you wanted to talk about workforce, you wanted to talk about HOP. Casey was like, I'm gonna just talk about everything while I'm on the panel. So, but I appreciate how you framed your comments and your reflections, and also the importance of this whole conversation. They are not siloed. It's not one panel speaking about one issue that sits or lives on an island unto itself. It's all interrelated. And so I want you to hold that as we commence here in a few minutes to talk about the workforce needs of Western North Carolina and the opportunities that exist before us. Joy. When we talk opportunities, you cannot sit in a space about the potential, what may come, what is possible, and not have joy in your hearts. This is a conversation and a discussion in which we should be joyous. The spirit should be one of levity, because we're talking about caring for people. We're talking about serving people. This room is filled with individuals who have dedicated themselves as decision makers, as scholars, as practitioners, as friends, to service others, to lift them up in an effort to improve their quality of life and their lived experiences. And so for that, I say thank you again. Now, having said that, I am Alex Howard. I come to you representing Dogwood Health Trust. I've been there just shy of 2 years. I have the privilege and the opportunity of serving as the Vice President for Health and Wellness. And in that role, I have a lot of new friends. So I say that jokingly, but I have had the opportunity to engage in a number of meaningful conversations in my time at Dogwood. And it's been humbling, and it's also represented a space in which we can imagine what is possible. And so I'm super excited to have before me today a diverse group of individuals who represent clinical practitioners, educators, administrators, decision makers in Western North Carolina that have a lot of insight that they wish to share regarding the workforce needs of our region. 17 years ago, I was a graduate student at the University of Kentucky. And during that time, I had the opportunity to work in our practice-based research networks and across the state's efforts to facilitate public health leadership initiatives. Workforce concerns were top of mind. The issues at that time, salary compression. How do we create a more diverse workforce? How do we create pathway and pipeline opportunities? How do we not lose people out of the Commonwealth to go and live and practice elsewhere? 17 years later, we're still having very similar conversations. So one of the things I ask of you today is, again, let's focus on opportunities, strategies by which we can recruit and retain and see a bolstering of the workforce here in our region. With that framework, we have before us Dean Hyatt, representing Southwestern Community College. Thank you for being here. We have Dr. Lombardi, a health services researcher. So my time at Kentucky, we build out the public health systems and services research. So at some point, you and I are going to get to geek out and just dive into the research into things. We have Rachel Bemis, who is the administrative director over at MAHEC. So thank you for being with us. Dean Anderson, great to see you again, joining us as the dean from the College of Health and Human Sciences at Western Carolina University, and then Dr. Hudspeth, who is the chief executive officer at Blue Ridge Health, one of our FQHCs in the region. So the first question that I am going to ask of the panel today: can you provide a brief overview of your organization that you are representing and speak about the importance of this conversation and the hope you have for what might come out of this conversation today? So Dean Hyatt, you are first, Dean Hyatt.
Good afternoon. Is this on? Good afternoon. Thank you for allowing me the privilege to be here to speak with you today. My name is Melissa Hyatt. I am a Haywood County native. Western North Carolina is my home. I'm very grateful, since we're talking about gratitude, I'm very grateful to be able to have the position of Dean of Health Sciences at Southwestern Community College. I accepted that position 2 years ago because I wanted to have a positive impact on the quality of health care of my home, of my region, for my family and for my neighbors. And I knew that one of the most significant ways that I could have that impact would be in the educational pipeline, being able to mold, produce, and groom our future healthcare workers for our region. Our philosophy within health sciences at Southwestern Community College is we're training neighbors to care for neighbors, because it does take a community. One thing that I noticed when I first joined Southwestern Community College was there was an absence of confidence and motivation within our region of individuals wanting to pursue a career in health care. So one thing that we have worked very diligently on in health sciences at Southwestern is to come alongside of those individuals to give them the confidence to pursue a career in health care. If you have the heart and the mind to care for your neighbors, we will equip you with everything else that you need to be successful. We have 17 health science programs at Southwestern Community College, so it is a very comprehensive division. We pride ourselves on being very in tune with our community and our community partners and having an ear for what that community needs. So once again, thank you for this opportunity.
Morning, y'all. I did the 450-mile day tour today, but I'm really happy to be here from Chapel Hill and back. I'm Brianna Lombardi. I'm here representing the Sheps Health Services Research Center program on health workforce research and policy, which y'all might be familiar. That's directed by Aaron Freyer. We produce NurseCast and medical student tracking and the health professions data system, which we evaluate the 21 health professions in our state. We certainly have more. I'm a social worker by training. I practiced as a psychiatric social worker working with adolescents. And then I really started trying to wonder, why was my practice being implicated by things like payment and systems? And that really drove me to go back and get my PhD, which I did here at Carolina. And so now I get to, look at data and numbers with a focus on the most vulnerable members of our community, and really thinking about how do we really take in this exciting investment that is Medicaid expansion, and how might that impact the workforce and access. So I'm the Deputy Director of the Program on Health Workforce Research and Policy, but I also direct the Behavioral Health Workforce Research Center, which is one of the 9 federally funded health workforce research centers in the country. We have 2 of them at Sheps Center. The Behavioral Health Workforce Research Center does what it says. We study and track the behavioral health workforce. And I'm excited to talk to you all about that. Certainly that is a focus of the conversation we've had this morning, but hopefully talk more about that. The important role that Medicaid expansion will have on meeting the critical behavioral health crisis in our state, and certainly for you all in this region. Thanks.
Thank you.
Good morning. I'm Rachel Bemis. I'm the Administrative Director for Department of Community and Public Health at MAHEC. You heard Dr. Hathaway give an amazing overview of the work that we've been doing in Western North Carolina at MAHEC for 50 years. Our mission is to recruit, train, and retain the next generation of healthcare professionals in North Carolina, in Western North Carolina, and we live into that mission every single day with the work that we do and with the programs that we support. So I'm really excited to be here today. I'm excited to have the conversation with all of you, and as I look around this room, I am just so struck by the fact that this work takes such a village. I see all of the partners in here that we work with and collaborate with on a regular basis, and we could not do this work without the individuals in this room. So excited to talk about workforce issues, excited to talk about all the great work MAHEC is doing in our 16 counties of Western North Carolina. So thank you. Thanks, Alex, for inviting us and moderating and for having us today.
Good morning. I'm Lori Anderson. First and foremost, I've been a nurse for over 35 years. I see a couple nurses in the back. My nursing career has really afforded me many opportunities to certainly be joyful and also be full of gratitude as well. So with that, I came to Western Carolina University 4 years ago. I came out of the Georgia system where I'd been there for 25 years. I came here to Western North Carolina, seeing the opportunity, seeing the excitement, seeing the workforce that could be grown. What excited me about Western Carolina University was the College of Health and Human Sciences, seeing all the healthcare disciplines together, knowing that interprofessional education is paramount to healthcare safety and quality. That's what really drove me there, going, wow, it's all there under one roof. Everybody was so excited to have opportunity to work together. I love clinical partners. I love our external stakeholders that we have, and just seeing what an impact we could potentially have as we work together to address workforce needs. When I came out of nursing school in the late 80s, nurses were plentiful. Actually, it was hard to get a job. And now that is not what we see now. And it's just like, wow, what a change. And it's like, how can we impact healthcare for the future? Knowing that, myself, my family have healthcare needs, it's like, oh, a little scary out there. So thank you for this opportunity, Alex.
Thank you.
Hi, my name is Richard Hudspeth. I'm a family physician and the CEO at Blue Ridge Health. In your packet, I believe there's a handout with panelist information. I certainly generally feel uncomfortable talking about myself, so I'll leave you to read that information yourself. Lori or Dr. Anderson, you said it proudly, 35 years. And when I wrote mine, it was like 30 plus years. I'm like, oh dear, I'm getting old or am old. So a little different reaction. So anyway, I want to tell you more and focus more on Blue Ridge Health, because really that's what we're here to talk about, is the delivery of health care. So Blue Ridge Health is a federally qualified health center, and it is a community health center. It started in 1963. As a migrant health center. We hold on to that original mission very dearly and continue to work with our migrant population. So that's really part of our DNA and continues today. We now serve approximately over 50,000 patients at 66 different sites in Western North Carolina in 10 counties. We cover, thank you. What we have been doing and continue to do is really what some of this transformation that we've seen in Medicaid and others is really about. Value-based care, integrated care. So our foundation is primary care. We also have behavioral health care and recently integrated with a behavioral health entity, Meridian Behavioral Health, in order to do and continue to do enhanced behavioral health services and provide primary care and other services for those patients. We do dentistry, including mobile dental buses going out to schools in many counties in Western North Carolina. The dental access is very challenging in Western North Carolina. We do pregnancy care, and we have physicians that do hospital care and deliver babies, myself included. And I was texting with a patient that I helped last week to make sure she's doing all right today. So I still am a practicing physician and still do obstetrics care. We also have pediatrics with specialty with us as well, pediatric neurology and pulmonology. We do school-based health, so half of our sites are school-based health centers. You can see our mission really to improve health, inspire hope, advance healing through access to compassionate, affordable, and quality health care. We have many, many trusted partnerships across Western North Carolina with health departments, other FQHCs, hospitals, and other local safety net providers. So excited to be part of this panel, and thank you all for being here, and special thanks to our legislators for being here. It is really, really heartening to see you folks here to learn some of the challenges that we are having, but also the joy of the profession that we are in.
Yeah. Thank you for those comments to each of you. And so, as a health services researcher, I'm going to point to you first to help lay a foundation. So the data, when we start talking about what is the landscape in which we are operating and centering this conversation. So Dr. Lombardi, if you would please share some insights on Western North Carolina, the state as a whole, how we might compare as we think about the health-related workforce.
Of course, of course. And again, I'm an outsider in Chapel Hill looking at this data, and so y'all please help have this be a conversation. But it is really exciting to talk about this data with you all who are living this. And so things that we're talking about on our team and from the data that we're seeing is nurse shortages is something that we are really concerned about. And particularly for Western North Carolina, we're tracking LPN, or licensed practical nursing shortages. So NC NurseCast that was released about 2 years ago looked at pre-pandemic workforce estimates for all regions of the state, but particularly by AHEC regions and Medicaid payment regions. And in Western North Carolina, RNs kind of was middle of the road expected shortages at about 700 RN shortage in 2030, but 600 LPN shortage, which is about half of the workforce of LPNs. Now, I'm not a nurse, although my sister's a nurse, and I love talking about nurses. LPNs are critical for long-term care and older adult care in our communities. I know as a region that is something that isn't, as on average, North Carolina is aging, but particularly in this region. We also know that long-term care and nursing homes are a way that stabilizes health systems because it unclogs hospitals being able to discharge into the community, but it also reduces burdens of families who are worried about their older adults, those that are caregiving. And so really thinking about how do we support an LPN workforce because of not just of the care of the individuals who are in their care, but of the broader ramifications. And so we've been talking a lot about, and y'all have heard about this, that we need to increase the production or the supply of nurses in our state, doing things through raising nurse faculty salaries, preceptor incentives, as well as creating new and exciting clinical learning opportunities like the one Mr. Cooper was describing at Cherokee. So I think there's multiple things that we could do, but we often in workforce only think about the supply or inputs into the workforce, and we talk a lot less about retention and sustaining. And we have a lot of less evidence, and probably that's why we mostly think about putting new people into the workforce than thinking about what keeps them in the workforce. But the good thing is that's really where communities can come together to identify what are things that keep individuals in your community, what supports might they need across their life course. You know, a 25-year-old nurse will need different supports than a 55-year-old nurse, and thinking strategically with health systems and communities about what will retain them. One thing, though, we're noticing from NurseCast is that a pandemic happened. And although there was ways that we could model the expected increase in losses in that workforce, we also know that that rejuvenated some people into joining the nursing workforce. And so we did see some increases in individuals interested in attending nursing programs. But one of the concerning things we wanted to flag for you when we're doing backcasting. So usually you do forecasting. What's our future shortages? But we were really interested in how did our forecasts, how correct were we? And we really identified a concerning trend for nurses between 25 and 50, where the greatest losses proportionally. Now, it's concerning to us because if you're losing nurses in the middle of their career, we're losing not just the largest chunk of the workforce, but we're also losing people where we would have expected another 20 plus years on their career. It's interesting, nurses 55 and older actually stayed in the workforce. We thought maybe they're at the end, they're like, we can hold on. But we really have to think critically about how do we re-engage nurses in that 25 to 50. The last thing I'll talk a little bit about that we're tracking is primary care and primary care shortages. The interesting thing too about workforce when we think about supply is we just think about numbers and we think a lot less about the distribution or the maldistribution. And it's, you know, when you look at kind of the rates of Western North Carolina, you all hang about in the middle in terms of regions. Not the top region, but certainly not the bottom region. But if you unpack Western North Carolina, there are huge differences in the proportion of primary care physicians in Buncombe County than in Clay County. And certainly these are things that are critical for us to consider is how do we work on the maldistribution of primary care physicians. And then again, I'm so glad you all talked about in the earlier is about Medicaid participation. And that's something I'm really worried about for our behavioral health workforce. So we know nationally, we don't have these numbers for North Carolina quite yet, that 30% of psychiatrists, only 30% of psychiatrists take Medicaid. So that means if we have, I think we have 1,600 psychiatrists in our state, only a third of them will serve our newly expanded Medicaid population. That has huge implications on who is able to gain access to care. And so, you know, something for us to kind of really think about is, for the behavioral health workforce, is Medicaid participation and trying to think creatively of what strategies we could do. We talked a little bit about easing credentialing, supporting, but I'm also wondering if we could really leverage our partners at the federally qualified health centers and other places to integrate behavioral health services, integrate psychiatry into those offices as a way to really expand access to care. Thanks.
Yeah, thank you. I also just want to call attention to Dr. Lombardi. We were going to talk about behavioral health a little later.
Okay, sorry.
But I know that's your thing, so you're like, we're going to talk about it now, Alex. So, and everybody wants to talk about behavioral health right now, and there's a reason to talk about it right now. We will double back on that, though. I have some very pointed questions I do want to ask you regarding the mental health workforce, behavioral health services. You also mentioned Asheville in Buncombe County. So for those of you familiar with the region, many of our conversations revolve around Asheville and Buncombe versus everyone else. And the maldistribution from resources, services, people, economic opportunities, so on and so forth. Dr. Hudspeth and Dean Hyatt, I have a question for the two of you. So Western North Carolina is described in a number of ways, largely rural, having a more senior population and limited economic opportunities compared to other sectors of the state. Thinking about this Asheville, Buncombe versus everyone else, how do those risk factors, or how have you seen them impact your clinical practice and the work you do now as an administrator in your various and respective organizations?
Want me to go?
I'll go.
Okay.
So actually, I began my educational career I'm a lab tech by profession. I am a product of the community college. I'm a first-generation college graduate within my family. So when I graduated high school, I attended AB Tech, got my associate degree in laboratory medicine, and then I returned back to AB Tech to work for 25 years as department chair for medical lab and phlebotomy. So I'm very familiar with the Asheville Buncombe healthcare culture and environment. There seems to be a great disparity once you leave Buncombe County and start west. It is a different culture. It is a different line of services that are available as well. And then when I went to work in Jackson County, what I noticed was there is also a mentality of local residents there, as well as there's a certain fear about going over the mountain and coming towards Asheville. So we have worked very diligently in opening up that mountain gateway to allow our students to actually come and do clinicals in Buncombe County and Henderson County as well for that. So that's a new world for them. That has helped us with our expansion. We have partnered with Advent Health, Pardee, of course, HCA and Mission, but we also work with our local hospitals as well. But what we have found is it does give them a new experience and a new culture in a new setting, but they always tend to come back home. They like home. They like their local community hospitals. So that is one thing that I've seen recently in our workforce development.
Great, thank you. It's a fantastic question, and part of our mission is to expand access. And that has meant for us expansion into counties outside of Buncombe and even Henderson, all right? We started in Henderson and Hendersonville. And as I mentioned earlier, we are now in 10 counties. And that's been our mission, right? To close the gap of access for care. And when we do that, we provide as many, if not exactly equal number of services that we're able to provide elsewhere, right? So primary care, integrated behavioral health care, prenatal care, dentistry, and do that in a number of ways. As I mentioned, we take our mobile buses out to where the need is, because to establish a brick and mortar dental site in rural North Carolina is very challenging, right? Just expense-wise, and again, trying to hire that for that need. What I would also say is that, I know you said sort of limited economic opportunity. What I see, healthcare is a driver of economic opportunity, right? We have seen numerous studies. When you put a family doc out in a community, it raises the economic value of that community, right? You put a family doc who's doing obstetric care, which we have, as I mentioned, we have family docs delivering at 3 different hospitals in Western North Carolina, right? We are recruiting for those folks, all right? And so when we help create an environment, or helping us create this environment for us, can stimulate rural economic development. And really, if I may just take a moment, indulge me for 30 seconds. There was a Greek physician many centuries ago. His name was Herophilus, who was the father of anatomy. And he basically said, when health is absent, wisdom cannot reveal itself. Art cannot manifest. Strength is without force. Wealth is useless, and intelligence cannot be applied. His point is that healthcare really drives everything else we do as human beings, right? And there are some that say it's a human right? But it drives everything we do as a human being. I also want to just, and I'm a little bit nervous about bringing this up. We have an expert on the panel, Dr. Lombardi, so I'll be interested to hear reactions. And I also hear from my son, who is a math major. He's like, Dad, you're an amateur when it comes to statistics and data and things like that. And it's like, he has, as any opportunity he has, he reminds me of that. But what I see, and we're going to talk, I'll reference some of this later as well, but I think we have a math problem here, right? So our birth rates in North Carolina have fallen 21% in the past 15 years, gone from 14.4 to 11.4. Our North Carolina population growth has averaged about 1%, just kind of hovers around that 1%, 1.3, 0.85, whatever, for the past 15 to 20 years. With a falling birth rate and that level of increase, that's really what we're calling in-migration, right? Those are people coming from other places, other states, other wherever, coming into North Carolina. And yet, so we're seeing this reduction in numbers. 47 counties in North Carolina have decreased in population in the last 10 years. In our region, as an example, and I know our representative is here, Swain County has fallen by 3.5% in the last 4 years. Another, Macon County, has seen growth, 5.7%, but in the 0 to 5 range has decreased, and greater than 65 has increased by 37%. Last I remember, our applications, there aren't many 65-year-olds and greater applying for jobs, right? And so we have to learn to do the proverbial more with less. How do we do that? Going to just mention a few things here, and some of it's going to be redundant because it was mentioned in the last panel, and then later on I'll talk about other things that we can do. But we have to think about how we can simplify the work we do. You know, we all go to the store, right? And I'm a little bit jealous because they have me doing their work, right? You're scanning yourself out, you're bagging your own groceries, and I'm jealous. It's like, how do I transform when I don't have the workers? How do I do that? And I think, I wonder what our patients would think if I said, here's a syringe, go draw your own blood. By the way, the x-ray machine is down there, go take your own x-ray. Healthcare is a very personal business. I need people. So I'm jealous, but I'm also glad because that's transforming the few people that we have. They're no longer going to be doing that job. We found a different way to have them work. Now we have to use our whole folks here in order to create that excitement about coming into healthcare. I also think, you know, that simplification. So we don't have to blow up the whole system to make our job easier. And I'm going to harp on 2 points that were mentioned in the last one. Credentialing. It won't take much. It will probably require legislation, but it won't take much to demand insurance companies simplify their credentialing process. I spend an inordinate amount of personnel time battling with that, lost income, as we've said, because these folks are not credentialed, right? It takes too long. Related to that is, we talk about a behavioral healthcare workforce that is desperate for workers, right? We're trying to find our LCSWs, our licensed clinical social workers, right? They're hard to find. There's reasons for that, and we can talk at lunch or some other time. But what we do have, thanks to our universities and partnerships, we have a lot of folks coming out and they're called associates. They're not fully credentialed yet, right? So we take them on, we have to supervise them, costs money, decreases the number of patients we can see. Guess what? Not all health insurances actually reimburse us for the care we're giving because that is associate level care. Change it. Force them to credential our associates when they are supervised appropriately, right? The last thing I'll mention again, redundant, is billing, right? And we don't have to create or blow up the whole system, but can we spend some energy just listening to us and figuring out how we can simplify the system? We've gone, you know, lots of changes in the Medicaid world, right? But from an administrative perspective, I understand the state's intention around managed care, but the burden of that took it off of the state and DHHS and put it on the providers. I now have 7 or 8 insurance companies I have to figure out how to bill for. I have an initial denial rate that ranges anywhere from 8 to 20%. That is work I have to do again. And already our EHR system uses artificial intelligence to drive these billings like, this one's good, let's send it, denied. That's more work that we have to do. I have to hire more people to do this, and we need to transform that workforce so I have more folks taking care of folks rather than doing the administrative burden behind what healthcare really does. And it's really just, there are so many things that we could simplify and still keep the system, relatively in place, but be more efficient with it. Dr. Howard, I'll shut up now.
I appreciate the insights. I was about to go and sit down. I was like, well, Dr. Hudspeth's just going to do his thing here. But no, thank you seriously for the insights there. And so what I'm going to ask that the audience does is begin putting in buckets some of these opportunities that represent strategies by which we, one, need to continue the conversation over lunch at the networking reception this afternoon to continue to engage around as well. So one being credentialing, and what that entails. How do we credential? And then looking at reimbursement, the complexities of reimbursable services. Came up with our CHWs and that, our peer support specialists, CHWs, all these things that we need to have more rich conversation around. So please begin to put those on your list of, I want to hear more, I want to learn more, I want to do more. The other thing I want to lift up was this question that was asked now by Dr. Lombardi and Dean Hyatt. Was questioning a statement, thinking about rural workforce and how do we recruit, but how do we also retain? And I love that you said they come home. People come home. The power of that statement and understanding how we create opportunities that might even be elsewhere, but then come back home. So I'm going to ask Rachel, if you will, to speak from the perspective of MAHEC, and this is going to lead into my broader conversation about training and educational services and opportunities. But Rachel, if you will, people know, I think, generally about the work of MAHEC, and Bill talked earlier today about the number of residents, physician residents that are coming in and in the pipeline, so on and so forth. I think lesser known is the work you all do in terms of that pipeline development. Exposing people, young people, our youngest residents, to the opportunities. Having conversations about, you may not feel comfortable or confident in going to medical school, but let's talk about becoming a CNA. So if you will talk to us a bit about the work and efforts of MAHEC as it relates to that pipeline and pathway efforts.
Yes, we have a very robust array of pathway or pipeline services at MAHEC, and believe it or not, we actually begin talking with students in middle school about health careers. And actually, for a while, I had a brain in a jar and some other various organs in jars on my desk, and people would come and grab them and take them out to a middle school and start passing them around and showing students, like, to try to inspire that interest, right? So really critical for us that we start really early on in the pathway with middle school students. We'd like to start even earlier at some point. We move through that pathway and we start to get more and more intentional about the time that our students spend with us and in healthcare settings in high school. And we really work with some of our flagship programs, including our MAHEC Medical Mentoring Program, which has been in place since 2005. It's one of our flagship programs. We take students, and for a semester, they come every single day after school for an entire semester, and they rotate through different physician offices. They rotate through different experiences. What we like to say is we want them to see what they can be, right? Some of these students are from disadvantaged backgrounds. They're first-generation college students, so we really try to give them that robust experience so that when they get to the undergraduate space, they have a better idea of the type of work that they're interested in doing. In the undergraduate space, we provide numerous opportunities in partnership with our community colleges, with our colleges and universities in Western North Carolina. We recruit students for summer internships and for other experiences so that those students at the undergraduate level can interact with us at MAHEC and really understand what the work might look like for them. And then we try to ensure that we are identifying opportunities for them within our UNC Health Sciences. So maybe they want to go to medical school, maybe they want to go to dental school, maybe they want to be a pharmacist, maybe they want to go into nursing. So we work with those students to try to connect them with their interests. School of Public Health, of course, is another opportunity that we direct our students towards. So this pathway is incredibly robust. And in fact, I told when I saw Dr. Anderson this morning, I said, oh, we just sent a group of 30 high schoolers this morning out from MAHEC starting at 7 a.m. So shout out to our team that made that happen. But we sent a group of 30 high schoolers to the Forensic Anatomy Lab to spend the day there at Western Carolina University. So these are the types of experiences that we are really trying to constantly, I heard Dr. Russell say, like, we've got to get creative with these workforce programs, right? So we're constantly trying to be more and more creative as we look at this pathway and we look at programming that really speaks to the interest of these students and attracting and connecting those students to our programming. So lots of exciting work going on. I'll stop there.
No, that's wonderful and truly core when we talk about growing our own and creating opportunities. So I just am so appreciative of the work you all do. And there are other efforts that exist within the region that I encourage all of you to learn more about in terms of our middle school and high school mentoring programs and coaching programs to, again, centering around career exploration and what opportunities might exist. So related to this, Dean Anderson and Dean Hyatt, so you all rich knowledge of workforce development opportunities and training opportunities within your various organizations. Can you speak a bit to the importance of these pathway programs, as well as how you connect and align your efforts with the needs of our local communities and the region?
Southwestern was blessed with a grant from the Dogwood Health Trust that allowed us to create a pipeline, a local pipeline. We titled it SHIFT, which stands for Southwestern Health Initiative for Teens. And we have a full-time shift coordinator, and we go weekly to middle schools and high schools. We take a network of SCC Health Science student ambassadors into those classrooms at the middle schools and high schools. And they will do things with those students, like they will do physical therapy on each other. They'll take the operation game and talk about surgical technology. So we're in the first year of that pipeline development. We're very excited about that, and we're getting a lot of feedback with that as well. One thing that I would like to speak to about health science education is the fact that throughout the decades that I have been in health sciences, I graduated in the 80s too, as a lab tech, but I've spent 27 years in health science education. And throughout those years, I can tell you this beyond a shadow of a doubt. Our health science education programs cannot survive, they cannot be successful, and they cannot produce competent healthcare workers without strong collaborative relationships with our healthcare facilities, our hospitals, our physician offices, our clinics. That is where the classroom meets the real work environment. And that is where those individuals develop into a healthcare professional. That's that final step from becoming a student to actually becoming a professional. So I cannot speak enough about the importance of community partnerships with healthcare providers, our educational institutions. You know, I always say the community college is either the first step for our individuals or maybe the last hope for an individual that is pursuing education. And so it is so very important that we have strong relationships with our universities for those individuals to continue on within their career pathway to a graduate level, a master's level, a doctorate level. But then also being able to have that positive, supportive relationship with our healthcare provider facilities, which we've seen a great improvement in that lately with scholarships being offered by hospitals, being able to help fund positions, faculty positions as well. Our health science programs are extremely expensive to provide, so I would like to see more collaborative partnerships between our community colleges. We just recently started a respiratory therapy program with Blue Ridge Community College. It is an SCC respiratory therapy program, but we're offering a satellite program at Blue Ridge Community College, therefore sharing the cost of providing that program, but being able to expand that health science education to our region as well. So I would really like to see an increase in those collaborative satellite health science programs within our region as well.
And Dr. Hyatt, you're right on target. It's about relationships. And over my 4 years that I've been at Western Carolina University, it's about those relationships. It's about listening. It's really about meeting the healthcare partner too. Certainly, you know, enrollment, we've been blessed in the fact that all of our health programs are maxed out and we're turning folks away. And that to me is really disheartening when I see that folks really want to go into a healthcare profession. So knowing that and then listening to workforce needs from our clinical partners, it's like, well, what can we do? So working together, yes, we've been able to get some scholarship money from healthcare entities. We've also been able to get positions, which has allowed us, particularly if we talk about nursing, has allowed us to increase the number of nursing students that we're able to have. The university also sees the workforce needs of the region because we're here to certainly provide for the region, and the university provided a faculty position as well. So we've been able to increase our nursing student production and out into the workforce. So that has definitely helped. Some other things that help certainly are the pipeline programs like Rachel has mentioned. We also collaborate with Cherokee Indian Hospital, and we have a great partnership there. And we're actually have a summer camp for our rural students and Cherokee students to get them interested into healthcare. So we team up certainly with MAHEC, and we team up with other healthcare institutions because students do want to go on to be a physician. Well, we do not have that type of education at Western Carolina University, but we need to help get that student into a program that will meet their need, with the hope that they're going to come back to the Western region, come back home, as was said. That's the biggest challenge, is getting them where they need to be and getting that right fit, and then hopefully they will come back home and provide that health care to all of us that are going to need it.
Thank you for that. So the two of you mentioned the importance of having the faculty lines to support additional students in the classroom. Can you speak a little more, just how do those faculty lines come about that are so important to having increased opportunity to train additional students? And having lived on that side, the absence of clinical preceptors and providers in the community that are important when we talk about this hands-on care that is given and the experiential education component. You have to have folk who are actually in practice to then send your folk to. Can you speak to those elements a bit for me?
Sure. Well, healthcare, as has been mentioned, to train individuals, it's very time-consuming and it's very expensive. Certainly, you cannot have a class of 20 and just turn them loose in a hospital. You can't do that. Particularly with nursing, I mean, that's why we have the nursing board of nursing. So they regulate how many our ratios can be, faculty to students, 1 to 10. So when you're looking at a faculty line, that's why, you know, it's so expensive, because we're in the clinical settings educating these students. Yes, our clinical partners are very important to us as we have nursing students in clinical entities, because yes, it's the nursing staff that's also helping educate that student, because you can imagine one nursing instructor with 10 novice nurses running around, and you're trying to keep track of everybody so that there's not a patient incident. It just takes time. It takes time to develop that confidence. It takes time to develop the competency that's needed as well. So with that, we try to, as I talk with our provost, I'm like, okay, if you want us to increase by 10, I need a new faculty line. That doesn't mean that, the didactic portion of class is needing that person, but it's the clinical person, the clinical portion that's needing that. What was the second part of your question?
Thinking through in the community the importance of those clinical preceptor relationships and having a robust availability of
So our clinical preceptors are very important because, yes, the nursing faculty may be between 2 or 3 units because when we're in these rural community hospitals, your units are small. It's nice to go into a huge academic health center because usually your units are probably 20 to 30 beds. So then if you descend on that unit with 10 nursing students, you can be in 1 unit. Well, when you're out in these smaller hospitals, you're probably going to be between 3 to 4 units. So that nursing faculty member's running up and down and who knows, between buildings. And so that puts the burden on the staff member that actually has the assigned patient that the student is assigned to. So now the staff person is really looking at, okay, patient, and then trying to help the nurse and student too. So it does cause a little bit of burden. It might, especially if you talk about nurse practitioners, certainly with primary care, if you have a nurse practitioner student with a primary care physician, now you're talking about impeding on flow of work and turnover so that they can get their cost production up by seeing how many patients. So that impacts their work.
So I would like to just shine a light on a couple of issues dealing with clinical education and our clinical affiliates. The Board of Nursing does they mandate how many nursing students that we can accept in a nursing program. But as far as our other health science programs, our enrollment is limited by the number of clinical sites that we can guarantee that our area hospitals will provide for us. We've talked a lot about it takes a village, it takes a community, it takes an entire team to take care of your health and provide quality, competent healthcare services to you. Without a respiratory therapist, you don't breathe. So nurses are on the front line and they are critical. And we are very, very grateful for the pay increase for our nursing faculty. That made a huge impact on us being able to retain nursing faculty. But don't forget the rest of your healthcare team, your respiratory therapist, your physical therapist, your radiography, that whole health science team. Retention of faculty is very challenging because at any point in time they can leave the educational setting and go back to the clinical practice and triple their salary. The reason we have faculty now is because they have a heart to educate and train. But it is very tempting to know that those salaries out in the public healthcare setting can be a lot more richer and a lot more significant. The other thing I'd like to shine a light on, and this goes back to the collaboration between our educational institutions within the region. I've talked about how expensive it is to have a health science program, so we're splitting the cost with Blue Ridge Community College to expand respiratory therapy. But think about this. You're a hospital, you're a healthcare facility, you have to take care of your patients, and you are short-staffed, and your staff is burnout, and they're trying to do more with less. Now you have all of these schools coming at you saying, I want you to take students, I want you to take students, I want you to take students. So they're having to balance being able to provide patient care while also helping to develop our workforce and train these students. And so those clinical site numbers are limited. Medical sonography. We have a sonography program that we can only guarantee 10 clinic sites for our service area. We have up to 50 applicants for sonography. So we have to turn away 40 because we can only place 10, because clinic sites are shared between educational institutions. And so I feel like if we could see more collaboration between our health science programs, more organization and collaboration with requesting these clinic sites, that's going to be able to enhance and increase the amount of our workforce as well.
Yes. The importance of multiple or co-investments across the space. The training sites, both in the academic classroom, but also in the clinical sites out in the community. They go hand in hand, and there must be mutual investments in both. Absolutely. So, Rachel, I'm going to ask you to speak to MAHEC's efforts kind of across all of this, because you all have this really cool vantage point from the training perspective as well as the provision perspective in recruitment and retention. It's a part of your charge. While you are speaking to that, I'm going to ask Dr. Lombardi and Dr. Hudspeth to begin queuing up a very rapid-fire response to our behavioral health needs in the region. And then I'm going to turn to you all and say, what do you got? What have you been thinking about over the last 45 minutes that we've been conversing, okay?
So at MAHEC, we really strive to incorporate learners of all type into every clinical encounter that we have in our facilities. And you're hearing all the shortages we have in clinical sites and preceptors, and that is absolutely felt by all of us all the time. That is really real. So for us, thinking about new ways that we can incorporate our faculty and our preceptors into our interactions with students is something that we think about all the time, really. The other piece that I'll add about workforce programs and the vantage point that we have as we look at recruiting and retaining the healthcare workforce in our 16 counties, right? So we're looking out to Murphy and we're looking up to Burnsville, and so we're looking at all the sites between here and there and everything in between. And we are playing a really long game. So if we're looking at a high school student right now that maybe went to Western Carolina University today that wants to go to medical school, well, ask me in 12 years where that student landed. You know, did they come back and practice? And what Melissa says is absolutely true. We love to recruit from our rural areas because we know that statistically, many of those learners will come back to practice in a rural area. So we've specifically designed some of our programs, such as our Rural Fellowship Program, around that concept to try to attract providers to come back to our rural areas to practice, whether it's medicine or psychiatry or maybe in the dental space. So we really look towards recruiting and retention in our rural areas as well. But it is an incredibly long game, and it takes a lot of patience for us to continue to stay the course, especially when we're looking at shortages of preceptors, shortages of providers in all of the areas. One of the things that is first and foremost in my mind is the fact that we have representatives from MAHEC. We have managers in each of our counties out in the western part of the state. We have regional managers that are assigned to a set of counties to look at students that are coming through the pathway that have interest in the medical field and try to feed those high school and middle school students into programming at community colleges, at universities, with the hopes that they will come back to practice in those rural areas that they came from. So we reach out to about 1,500 high school students in rural areas a year, again, trying to inspire that interest for them into a health career in a rural area.
Thank you. So I'm also going to make the connection for you. Where are my education specialists in here? Oh, quick, come on. All right, so chronic absenteeism, truancy rates. Anyone familiar with what we've been seeing over the last 15 years in our middle schools and high schools? If people are not present, you can't inspire them. If people are not present, you can't motivate them and show them the opportunities that might exist. But then you also have to ask the question, why are people chronically absent from attending middle school and high school? So I'm going to ask that you put that on that list of conversations we need to continue to have. The issues are complex. The strategies we have to design and deploy must also be complex. Behavioral health in the K through 12 setting, we know the needs continue to expand. We don't have the workforce to meet the needs. The severity of concerns that our children, the youngest members of our communities, that they're experiencing continue to increase. We have to address these issues. We have to figure this out. Dr. Lombardi, Dr. Hudspeth, if you would, please speak to the behavioral health needs of Western North Carolina.
Sure, thank you. And I'll also speak a little bit about Secretary Kinsley's strategic caregiving workforce report that I contributed a bit to on the behavioral health workforce recommendations for our state. And we have a lot of data on our need. You all know this. Less than half of those who want behavioral health care are able to gain access to it. Less than 10% of people who have a substance use disorder gain access to service and treatment. At the same time, we have rates of behavioral health needs, rising. About 20% of high schoolers in North Carolina have seriously considered suicide. And we know, and I looked at the data recently, in Western North Carolina has some of the highest rates of ED visits for suicidality, self-injury, depression, and anxiety. So, along with opioid overdose. So we have a lot of data of this, heartbreaking need that we all experience in our communities and unfortunately personally in our families. At the same time, we have almost negative data on behavioral health workforce. We have very little understanding of who is serving, who is available to serve us. And so advancing the behavioral health data landscape is so critical. South Carolina's General Assembly just recommended a funded study to look at South Carolina's behavioral health workforce. And I was speaking with those who were contracted, and I said, I wish North Carolina would do something like this. We have some understanding of psychiatrists and psychologists, and y'all know this, it's printed in your report. 4 counties in Western North Carolina have no clinical psychologists as their primary practice area. Where LCSWs are practicing, licensed mental health counselors, licensed marriage and family therapists, all these other workforces, we have really no idea. And although there's this huge investment in behavioral health through Medicaid expansion, we have almost no way to evaluate it. And no way to understand, are our reimbursement rate increases moving the needle to impact behavioral health access? So without the available data landscape, really understanding how do we calibrate reimbursement rate increases over time would be really quite difficult. So certainly advancing behavioral health landscape would be critical. And then I'll speak to, because we have many speaking about community colleges, is thinking about our unlicensed behavioral health workforce in North Carolina and how do we better utilize that. So I looked up all the community colleges in Western North Carolina. Several of them have human service technology associate degree programs, which are wonderful. These don't meet the requirements we have for regulation for qualified professionals in our state for mental health. They do for substance use, but not for mental health. So we have these training and regulation gaps. In workforce, we call it the 3-legged stool: payment, training, and regulation. And unless those 3 things are aligned, we really cannot deploy the workforce. So really thinking about, as a region, how do we combine community colleges, human service technologies with Western Carolina, App State, into these bachelor's programs and beyond is really critical. And that's all I'll say for right now. Thanks.
All right, I think that rapid fire was directed at me, your quote on that one, so I'll try and be brief, Alex, sorry. So first I want to address at least how our community health center is addressing the training needs, because I want to make sure people understand what we're doing. So for example, we train a lot of health professionals, and we have a collaborative teaching health center program with MAHEC. There are 5 graduating family physicians from our Hendersonville program. 4 of them will be staying in Western North Carolina with Blue Ridge, right? Many of our sites in Western North Carolina come through the MAHEC residency program. So that collaboration and keeping them local is super important. They may not have been born here, but they came here, they trained here, then they stay here, right? We also have trained nurses through partnerships with our universities. We had created our own internal medical assistant training program because that's what we needed to do in order to get people in the door to help us with that. We also have a training program for community health workers. So I appreciate what was said earlier. Guess what? there's limited ability for them to actually help us in reimbursement. So it's just a bottom line, like, yes, they do great work. We use them in our migrant work and other places that we do, but we pay for that. There is no really reimbursement for that. So I wanted to mention some of those things, and I talked about our associate level LCSWs as well. Specifically around behavioral health, what I'm going to say is I think there are things that we can do that can help ease this while we continue to manage sort of this need, crisis, and work with others to get it. So, for example, behavioral health telehealth is killing us, right? Killing us in the sense that companies are taking our workers. You can work from home. We're going to get reimbursed the same amount of money that you're going to, and we'll pay you more, and you could sit in your pajama bottoms on Zoom and do that all day, right? We provide telehealth as well, but we also provide in-person, brick-and-mortar behavioral health because this is a personal business. But our payment scheme is equal to what they do. So it's easier for them to hire some of these folks. We need to change that. If you're providing brick and mortar and telehealth, pay us more for that so we can keep and retain our employees to do the difficult work of behavioral health. The other is there are interstate compacts for therapists, just like we have for nurses, right? And Ohio, for example, allows bachelor level folks to do master's level work. We need to rethink about what those things are that you kind of mentioned earlier. And I'm going to mention one other thing, and this is just a way, and this is getting a little bit into the weeds, and I want to be rapid fire as Dr. Howard asked me to be, but just an example. All right, we integrated with Meridian. It's an enhanced behavioral health. There is a service called ACT, which is Assertive Community Treatment Program, right? I want to tell you what is required to do this program, just in people. Team leader, psychiatric care provider, nurse, substance abuse specialist, vocational specialist, peer specialist, additional staff program assistant. I can't find that in Western North Carolina, right? But we can do the work. So this is very prescriptive. It's not value-based, but it kicks us out of this sort of reimbursement program for ACT services. It's like, we can still help these folks, right? But it's become very challenging for us to help them because the reimbursement's all different, and it's like, you're not following this. You need these 8 people in order to do this service. No, we don't. Let us innovate. Let us innovate without, one of the issues is VIA tells us, right? If you don't do it, I've got to go and find somebody else who will. What a waste of resources when we can do that. They're not going to be able to do it either. So we're struggling. We need to innovate around let the professionals help us decide what is needed to help these folks, right? Let us innovate. Rapid fire, done.
I love it. I love it. All right, so with that, I am going to ask if there are questions from those of you attending and joining us. We do have the microphone that will be coming around. See over here at this table. So the blazer on here, and then the yellow. Yes.
Good afternoon, everyone. Thank you, panelists. I really enjoyed the discussion so far. My name is Mark McNeil. I'm a family physician in an independent small practice here in Asheville. I also got a side gig as the president-elect of the North Carolina Academy of Family Physicians. As a small business owner, independent physician. You're a MAHEC grad, too. MAHEC grad. 50th anniversary this year. Right, Dr. Hathaway? Okay. As a independent physician, small business owner, I appreciate the discussion about the workforce shortage on all levels. I've spent a month trying to get a certified medical assistant in my office. I can't find one. I'm also, as a president-elect of the North Carolina Academy of Family Physicians, I'm very much concerned about the lack of primary care physicians, our shortage in North Carolina. And there's been a lot of discussion about training, credentialing issues, admin burden. I would like just to highlight the investment or lack thereof in primary care. A few numbers. 50% of all visits to a physician in this country are to a primary care physician. Of every healthcare dollar spent in this country, only 6% goes to primary care. I think most people in this room would agree that's absurd. And so what does that mean? That means there's just not enough people going into primary care. We know right now we're short at least 400 primary care physicians in North Carolina. And that's only going to get worse as North Carolina continues to grow. I also know, I learned this morning, that the MAHEC just happened, and from an anonymous source, we had 600 family medicine residency physicians go unfilled nationwide this year. Okay? So that means training opportunities for family physicians that weren't going to happen. So that's some bad news, right? I do have some good news to mention, and I've got a question. Okay? Good news is that our General Assembly has been paying attention to this and put millions of dollars into scholarships to medical students going into primary care and psychiatry, and I want to thank them for that. Also, other states are starting to look at ways on how to invest more into primary care. There's about 10, 12 states working on this with good results. Rhode Island increased their investment from 8% to around 11% over 4 years. Helped with their workforce shortage and costs came down while maintaining quality. For every dollar they put in, $6 was saved. Every dollar they put in primary care, $6 was saved. Their system. The other good news is that our General Assembly, in collaboration with this health policy initiative and the North Carolina General Assembly, has put funding in last year for a primary care and payment reform task force, so which I remember. Who's going to be coming out with a report in a few weeks. We were tasked with studying what's happening with investment nationwide, what other states are doing, and making recommendations how to measure primary care in North Carolina and how to improve that investment in North Carolina. So I'm just sort of flagging that for legislators to keep an eye out for. We hope we can continue to collaborate with you on more action. This is where I'll turn to the panelists. This is where I'll just be interested in your input. If we could increase primary care investment, what would that mean to our workforce challenges in primary care, but also with behavioral health and nurses and medical assistants? Part of this, and the second part of that question is how we do it. Part of this, what we hope in this task force is to maybe move the fee-for-service to more value-based care payments and how that would affect it as well. So I'd be interested in your thoughts. Thank you.
All right. So what might be the impact seen or realized from greater investments in primary care, behavioral health, so on and so forth, and then how might we achieve that?
I'll just say thank you for that. And we are tasked to do medical student tracking, where we look at the proportion of North Carolina medical graduates that end up in primary care and end up in rural primary care. And we've been tracking this for over 10 years. And we're about to release our most recent findings, which is of the 2018, about 600 medical, North Carolina medical school graduates. In 2023, only 14 were practicing in rural primary care. And so investing in medical students is super important, but really being purposeful that medical students and residency training is also. So that's undergraduate medical education and graduate medical education. And we know graduate medical education, residency in rural areas is one of the primary predictor of practicing in rural areas. So I would encourage considering how some other states are using Medicaid GME to fund primary care rural residencies as a way to increase the supply. And I think also really thinking critically about physicians, but also other advanced practice providers in our area, and thinking about how we can maximize teams as a way to address our primary care issues in North Carolina. But certainly thinking about other payments where, we think about the quality of services, preventative services as being, having a return on investment as a way to increase. But thanks.
Mark, thanks. I appreciate those comments, and we look forward to your leadership at the Family Physician Academy for the state. What you're talking about is a tremendous effort of transformation, right? primary care as a foundation for the medical system in this country, and that's not really the way it is. So that's going to take time, and I'm not sure when it'll happen. I think it was Donald Rumsfeld who said, you go to war with the army you have, not the army you wish you had, right? And so I look at this in a very practical manner. We have what we have. We're short whatever number of primary care, whatever number, we're going to do what we can. And again, it requires us to think differently, to innovate, to simplify in order for us to get the work done for the patients that we need to see. I know Casey Cooper was here earlier. He may be having lunch already. Casey? Anyway, you know, he said, hey, we got 100 job openings. Well, we've grown threefold in the past 7 years. We've gone from 150 employees to 650 now. Have 120 job openings. It ain't gonna happen. I mean, that's the reality that we're faced with. It's not gonna happen anytime soon. So help us do the same work, simplify our work, let us innovate around these things. To me, that's the short-term answer. The long-term answer is to, yes, address these issues and figure out how we can radically change the way we think about primary care as a foundation for the healthcare system of our country.
Thank you. So I've been told it's time for just one more question. So if you have additional questions, please catch us at lunch or at the networking reception.
Good afternoon. I'm Chastity with statewide based out of Morganton in Burke County. First and foremost, thank you so much. Thank you for your dedication, for your profession, for all that you have done over 30 plus years to really contribute to the health and well-being of Western North Carolina. Two thoughts here. One, I wanted to share a program that is really growing in our community that may or may not be of interest to the rest of my colleagues here, and it's called Work and Burke. It's operated through an organization called the Industrial Commons. They're really looking at workforce development, not only healthcare, but healthcare is certainly a piece of that. Because when I look at our communities growing and bringing industry in and being able to pay living wages so that we can all, live healthy and well, we have to have an income that supports that. I find it really hard to be able to recruit new businesses into a community if you don't have health care, right? So, and I've got to look at my pad because I can't remember all this. Because I'm affiliated with Work and Burke because we are providing internship opportunities with our nonprofit. The Work and Burke, it's a collaboration between Burke County Public Schools, Western Piedmont Community College, Burke Development, and also it's operated by the Industrial Commons. So it's really working with students who are graduating and they're not real sure what they're going to do next. So they've allowed an opportunity, a collaboration between community, manufacturing, healthcare, small business owners, nonprofits, who am I forgetting, the trades, to really help our students gain that curiosity and experience going in and doing a paid internship, $12.50, $13, for them to get the experience. Hey, am I interested in being a medical assistant? Am I interested in going into carpentry? It allows the opportunity for curiosity, but it also goes back, Dr. Howard, that number one, you have to show up and be in the classroom. In our community, 26.8% of our kids live in poverty. That's a 10% above the state average. And I'm sure our good senator is aware of that. 25 to 44, this is ages, between ages 25 and 44, 59% of our residents don't have an advanced degree, whether that's a certificate, an associate's degree, a bachelor's degree. But then I'll pause, because we can increase all the curiosity, provide the opportunities. But where's the bottleneck? I heard it for the first time today because I'm not in healthcare. I heard it from Melissa, when you said the number of students are controlled by a certain organization. So how do you change that? Because you have students at Western Carolina, my alumni, paying my alma mater, thank you, that you're having to turn away. But yet there's a need. So where does that change? Who changes that? Does that start at the legislative level? Do we need to look at our legislators and say, hey, we need more funding, where does that start? Because you've got the interest, you just don't have the seats. Or at least that's my understanding.
Yes.
Thank you.
So one thing I'd like for you to think about at the community college, and I started at the community college and then went on to the university and got graduate degrees. But one thing I want you to think about at the community college, we are the ones that are literally cranking out the frontline, hands-on workforce. We're the ones cranking out your associate degree nurses, your practical nurses, your CNAs, your medical assistants, your sonographers, your respiratory therapists. Community colleges need funding to be able to expand our programs. You know, community colleges, we've always said we can achieve whatever needs to be done with what we have, and we're very good at that. We're very good at, like I previously mentioned, being that first step for an individual or helping that individual that we're their last hope. Funding is an issue for community colleges to be able to increase our enrollment. Faculty retention is a huge challenge, especially in health sciences, because as I previously mentioned before, getting competent, qualified faculty to stay when they know they can return back to the hospitals or the clinical settings and double or triple their salaries, it's really hard to keep that. So funding would definitely be able to allow us to retain and increase faculty, because we do have to meet those ratios of 1 to 10, you know, 1 faculty to 10 students or whatever. But I do feel like an easier answer also as well would be more collaboration between the community colleges and our healthcare providers, and being able to expand those number of clinical sites so we can accept more students and be able to get more students placed out in the clinical settings as well. But of course, we also know that funding is also the root of being able to do that as well.
Well, thank you. Thank you for the very thoughtful and rich engagement across the last hour. Dean Hyatt, Dr. Lombardi, Rachel Bemis, thank you. Dr. Anderson, Dr. Hudspeth, your insight, the wisdom you shared, extremely thought-provoking, but also, again, inspiring us to consider what are opportunities for us to engage deeper and begin to design and develop strategies to address these concerns, these challenges that have been entrenched for some time. So Dr. Lombardi used the language of payment, training, and regulation. So if you're asking yourself, where do we go to dig in deeper? Look to those 3 things: the payment concerns, the training concerns, and then the regulatory concerns. Thank you. Thank you all so very much. Much appreciated.